HEDIS, which stands for Healthcare Effectiveness Data and Information Set, is a program designed to measure healthcare quality primarily using health plan billing data. The HEDIS program is administered by NCQA, a national nonprofit, non-government agency that was founded in the 1990s. Through HEDIS measures, we can ensure comprehensive preventative care is delivered to the patients in our network, and we can use the measures to identify those patients who are due or overdue for preventative healthcare services. Today, 191 million people, a little over half of the population in the United States, are enrolled in health plans that report HEDIS quality measures. Each year, health plans, using information from physicians and physician networks, report HEDIS quality measure performance to NCQA. NCQA combines the data reported by hundreds of health plans on millions of patients to produce national performance benchmarks for most all of the measures in each of the domains of care. We can use these benchmarks to understand the quality of care provided to patients in the Steward Healthcare Network. Let's get started with the basics of quality measurement. First, we'll review some common quality measure lingo. Each quality measure has qualifications that must be met before a patient can be included in the quality measure. The denominator refers to all patients who meet the quality measure qualifications. For example, the Comprehensive Diabetes Care Measure only includes patients with diabetes, so the denominator population for the measure is all patients identified as diabetic. The numerator is the subset of the patients in the denominator population who receive the preventative care service in the time frame required by the measure. For example, one submeasure within the Comprehensive Diabetes Care Measure set is the number of patients with an annual A1C test. Patients are categorized as numerator compliant when they have received at least one A1C test in the current calendar year. Patients are categorized as non-compliant if they have not received an A1C test in the current calendar year. Even if the patient had received an A1C test last year, they will not be counted as measure compliant. Compliance can only be generated by receiving the test within the measure time period. Exclusions are clinical reasons why a patient should be removed from the denominator of a measure. In the example of comprehensive diabetes care, two types of clinical exclusions that would remove a member from the denominator are gestational diabetes and steroid-induced diabetes. Typically, Steward Healthcare Network has to collect and submit medical record documentation on an annual basis to substantiate the exclusions. Let's take a look at the anatomy of a performance measure. Figure 2 illustrates how a quality measure performance rate is calculated. The dividend is the denominator of all measure-eligible patients. The divisor is a subset of patients from the denominator who receive the quality-related service. Patients with clinical exclusions are removed from the denominator. The quotient is the performance measure score, which is usually expressed as a percentage. Figure 3 provides an example. In this example, all patients between the ages of 18 and 65 who underwent a total knee arthroplasty are in the denominator. Patients who had emergent cases or cases with a fracture were excluded from the denominator. Patients who were evaluated for pain postoperatively were considered numerator compliant. The performance measure score represents the percentage of patients who underwent the procedure and received a postoperative evaluation for pain. Documentation of quality measure related services can be found in many locations, including a primary care physician or specialist electronic medical record handouts, claims data from health plans, medical records from outside facilities, consult notes, and even current health information exchange data. Quality Measures 2021 Medicare Quality Matters. To review the quality measures and benchmarks, please visit the website listed below. Medicare Safety Measures. As the leading cause of both fatal and non-fatal injuries for older adults, falls are one of the most common and significant health issues facing people aged 65 or older. Moreover, the rate of falls increases with age. Older adults are 5 times more likely to be hospitalized for fall-related injuries than any other cause-related injury. It is estimated that 1 in every 3 adults over 65 will fall each year. In those over age 80, the rate of falls increases to 50%. Falls are also associated with substantial cost and resource use, approaching $30,000 per fall hospitalization. Identifying at-risk patients is the most important part of management, as applying preventative measures in this vulnerable population can have a profound effect on public health. Family physicians have a pivotal role in screening older adults for risk of falls and applying preventative strategies for patients at risk. All persons over the age of 65 under the care of a healthcare professional or their caregiver should be asked at least once a year about falls. Older persons who present for medical attention because of a fall, report recurrent falls in the past year, or demonstrate abnormalities of gait and/or balance should have a fall evaluation performed. This evaluation should be performed by a clinician with appropriate skills and experience, which may necessitate referral to a specialist. Screening for future fall risk measure is meant to ensure that patients ages 65 and older receive an annual fall risk screening. This measure denominator population includes all patients who are 65 years of age or older with a visit during the measurement time period. The numerator event is a screening for future fall risk at any time in the measurement period. Screenings can include documentation of no falls in the measurement period, documentation of a fall or multiple falls in the measurement period, documentation of any fall risk assessment tool administered by a physician in the measurement period, documentation of any fall risk assessment tool administered by a non-physician that is signed by a physician. Patients who are non-ambulatory or have other medical reasons documented by the physician are excluded from this measure. Medicare at-risk population measures. 6.7% of the U.S. population ages 18 and older, about 14.8 million people in the United States, in any given year have a diagnosis of a major depressive disorder. Major depression is the leading cause of disability in the United States for people's ages 15 to 44. Depression remission at 12 months. The depression remission at 12 months measure depends on the usage of the PHQ-9. The PHQ-9 stands for Patient Health Questionnaire and is a self-administered 9-item instrument based on the 9 DSM-5 criteria listed under Criterion A for major depressive disorder. The instrument aids in guiding criteria-based diagnosis of depressive symptoms and can assist in identifying treatment goals as well as determining severity of symptoms and guiding clinical intervention. Measurement-based care emphasizes the use of standardized assessments and other tests to help personalize care and guide treatment decisions. Just as a primary care provider would routinely check a glucose level to better inform their treatment plan for a patient's diabetes, routinely administering rating scales to monitor improvement and/or a change in mental health symptoms is considered best practice in providing optimal care. Routinely using a PHQ-9 to measure longitudinal changes and track treatment progress are associated with superior patient outcomes when compared to usual care. Assessments alert physicians to lack of progress, guide treatment decisions, and identify potential intervention targets, as well as assist in differential diagnosis. Assessments prompt changes in interventions if needed when things are not working, or can prompt step down in care after a patient's functioning has improved. The depression remission at 12 months measure focuses on patients ages 12 and older with a diagnosis of major depression or dysthymia who had an initial PHQ-9 score greater than 9. To be compliant for the measure, patients must have a PHQ-9 score less than 5 within 12 months of the initial PHQ-9 score of greater than 9. Patients are excluded from this measure when they have a diagnosis of bipolar disorder, personality disorder, schizophrenia, psychotic disorder, pervasive developmental disorder, or are permanent nursing home residents. Comprehensive diabetes care. Diabetes is the 7th leading cause of death in the United States. Diabetes is a long-lasting disease marked by high blood glucose levels, resulting from the body's inability to produce or use insulin properly. People with diabetes are at increased risk for serious health complications including vision loss, heart disease, stroke, kidney failure, amputation of toes, feet, or legs, and premature death. One of the critical indicators within the comprehensive diabetes preventative care measure set is controlling A1C blood levels. Controlling A1C blood levels helps reduce the risk of microvascular complications that can result from diabetes. Additionally, the comprehensive diabetes care measure suite includes blood pressure control, maintaining a blood pressure reading of less than 140 and less than 90, diabetic eye exam on an annual or biannual basis, and attention for nephropathy. Let's take a closer look at what makes patients compliant for the diabetic eye exam and medical attention for nephropathy submeasures. Patients are considered compliant for the diabetic eye exam measure if the patient has received a retinal or dilated eye exam conducted by an eye care professional in the performance period, or if the patient had a negative retinal or dilated eye exam conducted by an eye care professional in the year prior to the current performance period, or if the patient has had bilateral eye enucleation any time during the member's history through December 31st of the measurement year. Patients are considered compliant for the medical attention for nephropathy measure if they've had at least one of the 4 following items. First, evidence of nephropathy based on the diagnosis code submitted on claims. 2, a nephropathy screening or monitoring test, such as a urine test for albumin or a urine test for protein. 3, evidence of treatment for nephropathy, such as a visit with a nephrologist in the measure year. Or 4, patients who are taking ACE or ARB therapy during the measurement period are considered compliant for the medical attention for nephropathy measure. This slide shows you a list of ACE inhibitor and ARB medications that count as compliant for the medical attention for nephropathy measure. Controlling high blood pressure. Controlling high blood pressure will significantly reduce the risk of cardiovascular disease mortality and lead to better health outcomes like reduction of heart attacks, stroke, and kidney disease. The relationship between the controlling high blood pressure measure and long-term clinical outcomes listed is well established. This measure really focuses on ensuring that those patients who have been diagnosed with hypertension have an adequately controlled blood pressure reading with a systolic reading less than 140 and a diastolic reading less than 90. In order to determine measure compliance, This measure looks at the representative blood pressure reading taken from the last qualifying visit within the performance period. That blood pressure reading must have a systolic value less than 140 and a diastolic reading less than 90 in order to be considered measure compliance. So which blood pressure readings count? So blood pressure readings taken at a primary care physician's office by either the primary care physician themselves or a nurse or a medical assistant or a physician assistant would be included in the measure compliance evaluation. Covering primary care physician blood pressure readings as well as managing specialists to see the patient for hypertension could also have blood pressure readings that would be evaluated for measure performance. Blood pressure readings taken at an emergency room as part of an inpatient stay are self-reported by the patient or taken the same day as a major diagnostic test or procedure are not considered representative blood pressure readings and are not included in the performance evaluation for this measure. The representative blood pressure reading is defined as the lowest systolic value combined with the lowest diastolic value taken on the same date of service. Taking multiple blood pressure readings for patients who present in the office with an initial elevated reading is required for measure performance success. Best practices include having a physician retake elevated blood pressure readings after the medical assistant, using an electronic cuff, avoid rounding of blood pressure readings. So if the systolic value is 138, don't document the systolic value in the patient's medical record as 140. Use structured fields in the electronic health record to document all blood pressure readings. In addition to taking multiple blood pressure readings, it's also critical to ensure that best practices are used when taking those blood pressure readings. This infographic demonstrates some of the best practices around taking an accurate blood pressure reading. Ensure that the patient's back is supported. Don't talk to the patient during or between measurements. Ensure that the cuff is fit to the arm size. Have a quiet room with a comfortable temperature. Ensure that the patient hasn't smoked, had coffee, or exercised for 30 minutes prior to taking the blood pressure reading. Ensure that the patient has had an opportunity to empty their bladder and then relax for 3 to 5 minutes before the blood pressure reading is taken. Take 3 measurements at 1-minute intervals. Use the average of the last 2 measurements to determine the patient's blood pressure reading at that visit. Preventative health quality measures. There are 3 cancer screening-based quality measures. The first is breast cancer screening. Breast cancer is one of the most common types of cancer among women and the second leading cause of cancer death among women. The breast cancer screening quality measure includes women between the ages of 50 and 74. To be measure compliant, women between the ages of 50 and 74 must have a routine breast cancer screening like a mammography every 27 months. Women who have undergone a total mastectomy are excluded from the breast cancer screening quality measure. The breast cancer screening quality measure is based on the recommendations of the U.S. Preventative Services Task Force. The U.S. Preventative Services Task Force recommends biennial screening mammography for women aged 50 to 74 years. The decision to start screening mammography in women prior to age 50 should be an individual one. Women who place a higher value on the potential benefit than the potential harms may choose to begin biennial screening between the ages of 40 and 49 years. The U.S. Preventative Services Task Force concludes that the current evidence is insufficient to assess the balance of benefits and harms of screening mammography in women aged 75 years or older. As a result, the current breast cancer screening quality measure only includes women between the ages of 50 and 74. The second cancer screening quality measure is cervical cancer screening. When found early, cervical cancer is highly treatable and associated with long survival and good quality of life. The cervical cancer screening quality measure includes women between the ages of 21 and 64. The cervical cancer screening quality measure is also based on the recommendations of the U.S. Preventative Services Task Force. The U.S. Preventative Services Task Force recommends screening for cervical cancer every 3 years with cervical cytology alone in women aged 21 to 29 years. For women aged 30 to 64 years, the U.S. Preventative Services Task Force recommends screening every 3 years with cervical cytology alone and every 5 years when cervical cytology is done in combination with HR-HPV testing. Women who have cervical agenesis or have undergone a total hysterectomy with no residual cervix are excluded from the cervical cancer screening measure. The third cancer screening quality measure is colorectal cancer screening. Colorectal cancer screening quality measure currently includes patients between the ages of 50 and 75. On October 27, 2020, the U.S. Preventative Services Task Force released draft guidelines recommending that colorectal cancer screening begin at 45 years old for average risk individuals, which is a shift from the current U.S. Preventative Services Task Force guidelines that recommend beginning at age 50. This was in direct response to the increase in incidence of early age onset colorectal cancer and aligns with the American Cancer Society's 2018 recommendations that screening begin at age 45. It's important to note that the current colorectal cancer screening recommendations are still in draft form. As a result, the quality measure still only includes patients between ages 50 and 75. In the future, the quality measure may be updated to include the earlier age range. On the next slide, we'll go into more details around what types of screenings and what exclusions there are for the colorectal cancer screening measure. Patients are considered compliant for the colorectal cancer screening quality measure if they've had one of 5 appropriate colorectal cancer screening tests in the measure required time frame. The 5 tests are an FOBT, or fecal occult blood test, or sometimes known as a FIT kit. It has to be completed within the measure year to be considered measure compliant. A flexible sigmoidoscopy completed during the measure year or the 4 years prior to the measure year. A colonoscopy completed in the measure year or the 9 years prior to the measure year. A CT colonography completed in the measure year or 4 years prior to the measure year. A FIT DNA test completed in the measure year or 2 years prior to the measure year. Patients with evidence of end-stage renal disease, ESRD, dialysis, or renal transplant during or before the measure year are excluded from the measure. Additionally, patients who are pregnant during the measure year are also excluded. Another preventative care quality measure is the annual influenza immunization measure. This measure looks at the percentage of patients seen for a visit between October 1st and March 31st who received an influenza immunization or who reported previous receipts of an influenza immunization. The first and most important step in preventing flu is to get a flu vaccine each year. Flu vaccine has been shown to reduce flu-related illness and the risk of serious flu complications that can result in hospitalizations or even death. This measure includes patients who are 6 months of age or older. The numerator is based on the number of members within the age group who received an annual flu vaccine for seasonal flu. The last measure that we'll look at in the preventative care quality measure domain is the tobacco use screening and cessation intervention measure. This measure includes all patients who are 18 years of age or older. This measure looks at whether or not patients who are 18 years of age or older have been screened for tobacco use at least once in a 24-month period, and if screened positive, whether or not the patient received cessation counseling in follow-up to the positive screen. This measure is intended to promote adult tobacco screening and tobacco cessation interventions for those who use tobacco products. There is good evidence that tobacco screening and brief cessation intervention, including counseling and/or pharmacotherapy, is successful in helping tobacco users quit. Tobacco users who are able to stop using tobacco lower their risk for heart disease, lung disease, and stroke. This measure is also supported by the U.S. Preventative Services Task Force. The U.S. Preventative Services Task Force recommends that clinicians ask all adults about tobacco use, advise them to stop using tobacco, and provide behavioral interventions and U.S. Food and Drug Administration approved pharmacotherapy for cessation to adults who use tobacco. Further, the U.S. Preventative Services Task Force recommends that clinicians ask all pregnant women about tobacco use, advise them to stop using tobacco, and provide behavioral interventions for cessation to pregnant women who use tobacco. The U.S. Preventative Task Force concludes that the current evidence is insufficient to recommend electronic nicotine delivery systems for tobacco cessation in adults, including pregnant women. The U.S. Preventative Services Task Force recommends that clinicians direct patients who smoke tobacco to other cessation interventions with established effectiveness and safety. WellCare Quality Measure Domain. Annual well visits include comprehensive, age-appropriate preventative health assessments. WellCare visits are an important part of the Steward Healthcare Network quality program. It is important that all patients be seen on an annual basis for routine WellCare visits. Delivering WellCare each measurement year and accurately documenting and billing WellCare visits is required to support quality program success. There are 4 WellCare-based quality measures. The first is for babies turning 15 months old in the measure period. Babies turning 15 months old must complete 6 WellCare visits prior to the 15-month marker. Toddlers who turn 30 months old during the measure year must receive at least 2 WellCare visits between 15 months and 30 months. Children, adolescents, and young adults between 3 and 21 years of age during the measure period must have at least 1 WellCare visit in the calendar year. Patients 65 and older with Medicare insurance must have 1 Medicare annual well visit. In addition to completing the WellCare visits, there are some critical components that should be included as part of the visit in order to satisfy other WellCare-related quality measures. First, for kids between 0 and 2 years of age, all CDC recommended childhood immunization should be completed. For adolescents turning 13 years of age in the measure year, they should complete all CDC recommended adolescent immunizations. Females between 16 and 24 years of age should complete an annual chlamydia test. And lastly, patients who are over 65 and coming in for a Medicare annual well visit should have a Medicare annual well visit template completed. Let's take a closer look at the childhood immunization measure. This measure includes all patients turning 2 years of age in the measurement period. To be numerator compliant, children must receive all recommended vaccines by their 2nd birthday. The CDC recommended vaccines include 4 DTaP, 3 polio, 1 MMR, 3 HIV, 3 Hep B, 1 varicella, 4 pneumococcal, 1 Hep A, 2 or 3 rotavirus, depending on the series being administered, and 2 seasonal flu shots. Children who have had a seropositive test or documented history of illness for any of the following: MMR, Hep B, varicella, and/or Hep A are also considered compliant for those specific immunizations. There are numerous exclusions, some specific to immunization type and others general. The general exclusions include contraindication for a specific vaccine. Also, anaphylactic reaction to a vaccine or its components. Please review this slide closely to see all the other exclusions that are specific to the different vaccines. Now let's dive into the adolescent immunization measure. Patients turning 13 years of age in the measurement period are eligible for the adolescent immunization measure. This measure looks at the percentage of adolescents turning 13 years of age in the measure period who had the following immunizations before their 13th birthday: 1 dose of meningococcal conjugate vaccine, 1 tetanus, diphtheria, toxoids, and acellular pertussis (Tdap) vaccine, and 2 or 3 human papillomavirus (HPV) vaccines. There are some exclusions. First, anaphylactic reaction to the vaccine or its components is an exclusion for all immunizations in this measure, and for Tdap only, encephalopathy is also an exclusion. This section covers condition management related quality measures. Osteoporosis management in women. Osteoporosis is a serious disease affecting mostly older adults that can impact their quality of life. Osteoporosis is a bone disease characterized by low bone mass, which leads to bone fragility and increased susceptibility to fractures of the hip, spine, and wrist. Osteoporotic fractures, particularly hip fractures, are associated with chronic pain and disability, loss of independence, decreased quality of life, and increased mortality. With appropriate screening and treatment, the risk of future osteoporosis-related fractures can be reduced. Osteoporosis management in women measure includes women who are between the ages of 67 and 85 years of age. All women within the age range who suffer a fracture between July 1st of the year prior to the measurement year and June 30th of the measurement year are included in the measured denominator. Women are considered compliant for the osteoporosis management in women measure when they have either a bone mineral density test, a BMD, or a prescription for a drug to treat osteoporosis within 6 months of the fracture. Fractures to the fingers, toes, skull, and face are not included in this quality measure. Statin therapy-related quality measures. Cardiovascular disease is the leading cause of death in the United States, causing approximately 1 of every 3 deaths in the U.S. One study that surveyed U.S. cardiology, primary care, and endocrinology practices found that 1 in 4 guideline-eligible patients were not on a statin, and less than half were on the recommended statin intensity. Untreated and undertreated patients had significantly higher LDL-C levels than those receiving guideline-directed statin treatment. In general terms, the benefits of statins to prevent non-fatal myocardial infarction, revascularization, stroke, and CVD mortality far outweighs any potential harm related to the drug. We're going to take a look at 2 specific statin therapy measures. The first is statin therapy for patients with cardiovascular disease, and the second is statin therapy for patients with diabetes. Males between the ages of 21 and 75 and females between the ages of 40 and 75 are included in the cardiovascular statin measure. Patients who have both cardiovascular disease and diabetes are included in the measure if they're between the ages of 40 and 75, regardless of gender. Members within the age range and have a diagnosis of arteriosclerotic cardiovascular disease, also referred to as ASCVD, are included in the measured denominator. For patients in the cardiovascular disease measure, they must receive a statin of moderate to high intensity at least once during the measure year. For patients in the diabetes and cardiovascular disease measure, they must fill a statin of any intensity at least once in the measurement year. Members in hospice who are pregnant or have ESRD or some other conditions are excluded from the measure. Atherosclerotic cardiovascular disease covers many different types of conditions. This slide gives you a rundown of the conditions that are under the umbrella of ASCVD. First, acute coronary syndromes, myocardial infarction, angina, stable or unstable, patients who have had a CABG, patients who have undergone PCI, or other revascularization, patients who have a diagnosis of ischemic vascular disease, IVD, or have had a stroke or transient ischemic attack, a TIA. Peripheral artery disease of arteriosclerotic origin. Please note that an active diagnosis is defined as a diagnosis that is either on the patient's problem list, a diagnosis code listed on the encounter, or is documented in a progress note indicating that the patient is being treated or managed for the disease or condition during the measure period. Medication reconciliation post-discharge. The medication reconciliation post-discharge quality measure includes all patients 18 years of age and older who had an inpatient discharge between January 1st and December 1st of the measurement year. If a patient is readmitted or directly transferred to an inpatient care setting within 30 days of discharge, the final discharge date is included in the measurement period unless the date is after December 1st. The original discharge is not counted for the measure. Practices must ensure that medications are reconciled by a prescribing practitioner, clinical pharmacist, or registered nurse, no later than 30 days after the patient discharge date. Evidence of reconciliation and the date it was done must be documented in the outpatient record. Documentation in the outpatient record must include evidence of medication reconciliation and the date when it was performed. Any of the following meet criteria: documentation of the current medications with a notation that the provider reconciled the current and discharge medications, documentation of the current medications with a notation that references the discharge medications, for example, a notation that says no changes in medication since discharge, or same medications at discharge, or discontinue all discharge medications. Documentation of the member's current medications with a notation that the discharge medications were reviewed. Documentation of a current medication list, a discharge medication list, and a notation that both lists were reviewed on the same date of service. Documentation of the current medications with evidence that the member was seen for post-discharge hospital follow-up with evidence of medication reconciliation or review. Evidence that the member was seen for post-discharge hospital follow-up requires documentation that indicates the provider was aware of the member's hospitalization or discharge. Additionally, when billing medication reconciliation, physicians should use CPT codes 99483, 99495, 99496, or CPT2 code 1111F. Please note that members who are in hospice are excluded from this measure. Performance improvement best practices. Performance improvement best practices include three main components. First, pre-visit planning. Audit the member's chart to determine what quality measures the patient needs at the time of their office visit. Check screenings, for example, the PHQ-9. Check consult notes with specialists, example, endocrinology. Check lab results, check surgical history, check historical claims, check medication list. Check to see if the following are in the patient chart. Is a quality alert in the patient chart or a sticky note indicating that there are gaps in care? Is there an additional note in the upcoming appointment? Morning huddles. Review the provider schedule for the day with office, staff, and provider. Discuss each patient in detail and what is needed for their visit. Determine who will capture everything needed for each patient. Post-visit planning. Was the patient referred for any additional screenings? Were any labs ordered? Were the patient's vitals documented properly? Does a referral need to be generated for the patient? Escalate to the office manager if you run into a barrier. Telehealth. When billing telehealth claims for services delivered on or after March 1st, 2020, and for the duration of the COVID-19 emergency declaration, include place of service, POS, equal to what it would have been had the service been furnished in person. Append modifier GT to indicate the service took place via telehealth. The majority of telehealth services require patient consent. This can be completed verbally or in writing and should be documented in the patient's chart. Documentation requirements for any form of virtual care are the same as those for documenting in-person care. CPT-2 codes. For many quality measures, the outcome of the service is not part of the CPT code or ICD-10 diagnosis code. CPT-2 codes can be used to supplement and drive compliance for quality measures. Please refer to this list of CPT-2 codes for multiple quality measures.